It's our distinct pleasure to present the Global Health Education Consortium Distinguished Service Award to Harriet Fulbright for outstanding and dedicated leadership in global health for the year 2009. Harriet, we salute you.
Thank you so much. I appreciate that. I'll do this. There.
Hello, I'm Cindy Hock, and I'm director of the Center for Global Health at the University of Wisconsin, and also the recipient of 2 Fulbright Awards, first to Pakistan and then to Uganda, to help establish family medicine in those countries and regions. So I'd like to thank you and the late Senator William Fulbright for changing my life and really the life of so many others, because these experiences gave me the opportunity to really understand, collaborate, and then pass those lessons on to others. So thank you, first of all, very much. And second, I wonder if you can tell us a little bit about your late husband and how did this idea come to him to establish such a remarkable program?
Thank you. My husband was an extraordinary creative and intuitive thinker, and it was partly his upbringing. I gave a whole speech on that, but I won't do that now. It's not quite time. But right after the Second World War, he was truly horrified by this new weapon, the atomic bomb, and what it had done to Hiroshima and Nagasaki. And so he held hearings in the Senate about the long-term effects of the bomb and its radiation. Because he was a professor before a politician, which he told people for the rest of his life, I was a professor before I was a politician. He invited a full range of experts from certainly environmentalists, biologists, different types of doctors, even a psychiatrist to do the testifying. He was so horrified by what he heard from them that he spent months thinking, talking to everybody who would listen, and even to those who tried not to, what can we do to help prevent World War III? And slowly but surely, after all these conversations, what became clearer to him was that that little island north of Europe was to him, thanks to the Rhodes Scholarship, a group of truly wonderful friends, a network of people who helped him for the rest of their lives. And if he could persuade future potential leaders to go and sit in a different culture, learn a different way of being, that perhaps when they did become real leaders, they would be far more willing to exchange ideas instead of bullets. That was the beginning of the program.
Morning. My name is Kaveh Khoshnood. I'm from the Yale School of Public Health. My question is related to the question from Cynthia Hock, and also the last sentence in your biography talking about your commitment and the commitment of your late husband to prevention of conflict. The topic of health and conflict, or sometimes we hear the term global health diplomacy, is emerging. And I'm wondering whether you see the Fulbright program getting involved in supporting young leaders who want to look at the long-term negative consequence of conflict on health, but perhaps more importantly, what health and public health people can do to prevent conflict to begin with.
That's a wonderful question, and I'm glad you've asked it, because it allows me to introduce the most immediate work that the Fulbright Center is doing in prevention of conflict, and that is something called the Global Symposium of Peaceful Nations. A friend, Australian friend, who wanted to give back to the world, created something called the Global Peace Index when he discovered that while war, violence, and terror had all kinds of statistics and analysis, peace, literally zero. And so he hired an impressive number of researchers from the Economist Intelligence Unit, and it took them almost a year, but they put together a series of very clear, concise, there are 24 indicators of peace in any nation and drivers, and then they ranked 140 nations from 1 to 140, and they review these each year. This year, the most peaceful country is Iceland, and the least, Iraq. What we are doing, we divided the world into 9 different regions because the most peaceful countries globally are clustered around Western Europe and Scandinavia and so forth. The 9 regions, and we are pinpointing the first and second most peaceful country in each of these 9 major regions so that the whole world is involved. Then in early November, we are having a conference. 1 representative who is a government person and 1 a private leader from each of these 18 countries will come together and truly discuss. We are also doing a lot of research ahead of time, but discuss their peacefulness, how they got there, how they're going to maintain it, how they are going to help their neighbors raise the level of peacefulness. The Global Peace Index helps us divide the means of peacefulness into manageable and things that we can focus on. So it has been a very exciting project. Thank you.
We have to ask you, where does the United States rank on that Global Peacefulness Index?
97 out of 140. I have a feeling that this year they will rise a little bit because I'll tell you, one of the factors that puts us down so low is that we have the greatest prison population of any country, either developed or developing, in the world. And we've got to do something about that.
If I could just add one comment, and this is important for us here as a group, is that with peace and bringing in access to health care and improvement of health care, the populations rapidly, there's very few modalities which can get populations on board by realizing they have better access and feeling better.
I would like to say, to follow up on that, you are absolutely right. There are 2 real drivers of peace. One of them is good health, and the second is education.
Harriet, that was a very inspiring talk, and especially the part that you bring up about war and peace. Essentially, it all lies in human behavior, whether you talk about ill health and good health, or war and peace. And we always wonder why there are lots and lots of statues and monuments to war, and hardly any for peace. I'm sure you could do the ranking of several countries based on that, too.
Yes, Washington is well known for all its many, many statues of soldiers on horses charging down various avenues.
This has just been a wonderful morning. Thank you very much again. Let's give Harriet a hand.
I want to welcome you to this plenary panel on the role of universities in global health, where 5 years ago, only a handful of US universities had programs they called global health. Now there are over 150. This huge shift is driven by the interest of faculty and students and the availability of unprecedented funding for global health from both the US government, foundations, and the private sector. I believe the interest of students, residents, and faculty in global health arises not only from idealism and the desire to give back, but also from an interest in a new career pathway. Universities have an opportunity to play a transformational role in global health by helping train the health workforce, building institutions in developing countries, strengthening relevant research, and by providing patient care, all intended to improve the health of people in low-income countries. But traditional universities in the developed countries have a special handicap. Their education programs are not necessarily based on the need of the people they serve and are tilted to basic science and the provision of tertiary care. Our medical education has insufficiently addressed the needs of the poor, the inner cities, and the rural regions, and health disparities are prevalent. This plenary panel will feature innovative medical education built on social accountability principles and a new initiative by PEPFAR to significantly expand the role of universities in global health that goes beyond their more traditional roles in research and technical support. So I'm delighted to introduce the first speaker, Dr. Fortunato Cristobal, the founding dean of the Ateneo de Zamboanga University of Medicine in the Philippines. Dean Cristobal developed this medical school in 1993 with a radical vision and innovative teaching and learning processes. Dean Cristobal, thank you for making the long trip from the Philippines to share this unique experience with us, Dr. Cristobal.
Good morning. While I was preparing for this talk, it has crossed my mind to ask myself, what can I share in 10 minutes' time?
Don't forget the discussion.
I come from the Philippines, a small country, populous but poor, and also from a small university town, and perhaps the smallest in the world. The question that probably I would want to ask is, what can a small town medical school contribute to global health? What would be the role that we can play for global health? 15 years ago, we started a medical school with a desire to produce health manpower for the region, but as well to solve the problem of the region with a population of 3.5 million people. The area where I come from is one of the most underserved regions in the Philippines. It has an infant mortality rate of 85 per 1,000 live births, and 85% of the municipalities are unserved. There are 38 medical schools in the Philippines, all of which are discipline-based. The Philippine Medical School, unfortunately, having no model to emulate from, decided to adopt the Western medical curriculum. In retrospect, however, we now realize that it has failed to serve us well. We have had this problem of medical diaspora. Our graduates are more prepared to sell elsewhere, but are ill-prepared to sell our own region. Thus, in effect, we were contributing to the disparity of health between the developed country and the undeveloped countries. The principal role of the medical school, I believe, is to produce human health resources for its own country's need. To do this, it has to do research and to create new knowledge that will enhance the development of the individual health care as well as the population health care. They have to be socially responsive. I believe we cannot expect other countries to solve our own problems. We have to solve our problems ourselves. In that way, we therefore have to think locally first before we can think of global issues. A medical school or a university can serve to remain neutral. In the guise of academic freedom, a lot of these medical schools can pursue prestige as well as academic excellence, and even develop objectives technologically and scientifically in isolation and become comfortably oblivious of the obvious medical health problems they are in their doorsteps. This attitude has led to a painful situation in the Philippines. A premier medical school in my country can boast of a brain surgery development in progress, however, is unable to avert cholera that has taken place about just 5 kilometers away from its doorstep. Sensing that this was not the kind of medical school that we desire, we decided to be radically proactive. We collaborated with the actors of the main society to develop a new curriculum. This we decided to call as the Health Development Project of Everyone. And the agents of change are our graduates, our students, our faculty, and the community at large. To do this, we had to debunk the traditional curriculum, expose the students to the current realities of our situation, democratize our screening for admissions, and to do more collaborations with the community. The local health priorities, as well as the national health priorities of the government, became the core curriculum or academic. Good health, we believe, is a default condition of disease and illness, but the reverse is also true, that the disease and illness is the default condition of good health. Therefore, it follows that factors for good health should be embedded right within our curriculum. The biomedical care, or the individual health care, has to be positioned in a social, cultural, and political context, particularly in the community context. Individual health care, as well as the population health care, are two skills that the students have to develop and are intricately related and connected to each other. Health is socially produced. If the immediate problem presented by the patient is a medical problem, it is a biomedical. The continuing integrity of the individual and the community will largely depend on the social condition of the country. We therefore expose our students 50% to clinics, as well as 50% on a community-based education. We use the communities to help to form the values of the students, but we also use the students to transform the communities. In time, we have been able to produce 168 board medical certificate graduates. This is the Philippines. They are now situated on these areas in the island. We have improved the infant mortality rate, which was initially at 50 to 80 per 1,000 live births, and in 10 years' time, we were able to reduce it to 5 to 17 per 1,000 live births. 95% of our graduates are in the country, and 90 are serving in the region. Only 5% have gone abroad. But they have served at least 4 to 6 years before leaving. 73% are with its government services, 50% are serving in the doctorless area. We have started local, we have become Asian. The country of Laos and the country of Nepal has invited us to help develop the curriculum program. In a sense, therefore, we have become global. Initially, we thought that we have to be globally competitive. And to do that, we have to be equal with the global standard. But then we thought that by doing that, we will be doing well. But in reality, we realized that this global standard has led us to do inappropriate things. As a result, we decided to reverse things. We decided to be ourselves, independent, self-critical, and self-respecting. Going back to the first question, what can a small medical school contribute to the global health? I think I can proudly say that we did by taking care of ourselves first, by breaking away from the global model to becoming independent and self-reliant, to develop a curriculum that suits ourselves and our culture to address our own health needs, rather than to be so biased towards the global curriculum model in the desire to be globally benchmarked. We have learned the lesson that for global impact, we have to think and act local first. Thank you.
Thank you all for coming this afternoon. I'm Chris Elias, the President and CEO of PATH, the Program for Appropriate Technology in Health, an international non-governmental organization headquartered here in Seattle. And it's my pleasure this afternoon to be able to moderate this panel on looking into the future. What is government's role in public health interventions? And we have two wonderful speakers and discussants for today's panel. The format will be that I'll do a very brief introduction of our two presenters. They'll then each speak for about 10 minutes each, and then I will ask them some questions, get a conversation going, and then we'll open it up for your questions and comments from the audience. When we get to that point, if you could come forward and use the microphones at the front, because they're taping the session, and so it would be very good to capture your questions on the tape. Our two presenters today are Stephen Gloyd, who's to my immediate left, who's a professor in global health and health services here at the University of Washington. He's also executive director of the Health Alliance International. Steve is a family practice physician and a member of the UW faculty since 1986. He's worked for 30 years in Africa, Latin America, and Asia as a clinician, manager, researcher, teacher, and policy advocate. His work is focused on improving primary health care, including maternal and child health services, tuberculosis control, and sexually transmitted disease and HIV/AIDS. He's written and spoken extensively on the political economy of global health care and the connection between neoliberalism and health. In addition to teaching and research, Professor Gloyd directs the Education and Curriculum Office of the University of Washington's Department of Global Health. His work with Health Alliance International is designed to strengthen healthcare with the Ministries of Health in Mozambique, Cote d'Ivoire, Sudan, and Timor-Leste. Dr. Gloyd received his BA and MPH from Harvard, his MD from the University of Chicago, and did his residency here at the University of Washington. Our second presenter today is Dr. Christopher Murray, who's the Institute Director of the Institute for Health Metrics and Evaluation and Professor of Global Health at the University of Washington School of Medicine. A physician and health economist, Chris's work has led to the development of a range of new methods and empirical studies to strengthen the basis for population health measurement, measure the performance of public health and medical care systems, and assess the cost effectiveness of health technologies. The Institute of Health Metrics and Evaluation is focused on the challenges of measurement and evaluation in the areas of health outcomes, health services, financial and human resources, evaluations of policies, programs and systems, and decision analytics. Dr. Murray's early work focused on tuberculosis control and the development with Dr. Alan Lopez of the global burden of disease, methods, and applications. Chris has authored and edited 14 books, many book chapters, and more than 130 journal articles in internationally peer-reviewed publications. He also holds a BA from Harvard College, a Doctor of Philosophy from Oxford University, and an MD from the Harvard Medical School. Please join me in welcoming them today in our discussion of the role of government in public health interventions. I think this is quite a time. This is quite a timely topic because it runs through quite a few of the recent developments in global health. If I think back 10 years ago I was living and working in Southeast Asia, and the field of global health a decade ago didn't have nearly the visibility or the resources that it has today. I sometimes say that a decade ago we would do important small-scale projects, finish them, and the last paragraph of the report would always read, "We're very encouraged by these findings, and if anyone ever gets serious enough to put some political will and resources into this, we could make a really big difference." Well, I think one of the things we've seen over the last 10 years has been a dramatic change. The amount of resources in global health have gone up dramatically. We've seen a significant evolution in the global health architecture, the way that governments and non-governmental organizations, private sector organizations, come together to work together to improve the health of people around the world. We've seen important new mechanisms and institutions evolve. A decade ago this year, the Global Alliance for Vaccines and Immunization was launched as a new way of coordinating the multiple stakeholders engaged in improving immunization systems around the world. Just in 2002, the Global Fund for Fighting AIDS, TB, and Malaria was launched. And since that time, just in the last 7 years, has raised and dispersed over $8 billion to countries engaged in the fight against AIDS, TB, and malaria. So we have some important new institutions, important new resource flows, and a dramatic increase in the political attention within the United States, as well as in the G8 nations, the G20 nations just last week in London, about the need for poverty alleviation and the improvement of global health and the reduction of substantial inequities in global health. Just last week, the Congress voted to maintain the significant increase in the international affairs budget that had been proposed for the 2010 budget by the Obama administration, in a unanimous vote in the Senate to support the Kerry Lugar amendment to the budget to restore those funds. These are not the kinds of debates that happened a decade ago. And so with all of the new attention and all the new resources, the roles of the different actors, and in particular the role of government, both in first world governments in terms of their support for global development, but in particular for national country governments as they try to make decisions and manage the increased attention and resources for addressing important global health problems, is beginning to shift. And so I think it's a very important time for us to consider this question of the government's role in public health interventions. And with that, I'm going to turn it over to our speakers and ask Steve to go first with his comments, and then I'll ask Chris to go immediately after that, and then we'll start a discussion. So thank you. Steve?
Thanks very much, Chris. I think I'll talk from here as well. I don't have any slides. What I'd like to do in about 10 minutes is to talk a little bit, mostly from my personal experience, about the role of government and what I see as the potential role of the private sector in the delivery of health services. As Chris was saying, that we're looking at this bubble of resources that provides a pretty amazing and I think unprecedented opportunity to move ahead in a number of potentially different directions in global health. And I think it's important at this time to gauge the evidence as to what kind of approaches are likely to make the most sense, where we're going to get the best bang for the buck, and particularly how we're going to how we're going to provide services for the poor. I'd like to use my age as an advantage in this discussion, and to talk about what I've seen as an evolution of thinking in primary health care over the last 30 years. It was 30 years ago that I went to Mozambique, actually this month, to start working for the government of Mozambique as a frontline health worker. A couple of things have happened that have made me kind of wonder what drives this debate and whether it's driven by evidence or whether it's driven by ideology. And my sense is that from both sides of the debate, it's driven by both. A couple of stories. One is several weeks ago, I had the great opportunity to have an informal lunch with one of the leading lights of global public health right here in Seattle. And we were both bemoaning the fact that government health services have really failed over the last couple of decades. And he was pushing, I was saying that it would be nice to sort of see if government health services could work, and he was pushing private health service delivery. And so I asked him, where's the evidence for it? Where's the evidence that private sector delivery actually works? And he responded that, there's this great project in Lesotho where the Lesotho government, the Ministry of Health, is in fact now subcontracting a private sector for-profit entity to provide health care for the hospital networks of the 3 largest hospitals in the country, which is a pretty substantial piece of their primary health care. And it's just starting up. I looked in the web to see what was going on with it, and in fact, it's, the contracts are just coming out. Well, that's the kind of evidence that I think most of us are seeing, which is a lot of good ideas, but not necessarily much evidence of what's happening. The other story is my own experience as a patient and as a provider. I've worked both in the private and the public sector in ministries of health in a number of places, particularly Mozambique. And in 2002, I happened to be about a block from the guest house I was staying in a place called Beira in Mozambique. And I was jumped. I was assaulted right after the city lights went out. It was a beautiful evening, but no moon, and suddenly it became absolutely dark. I was jumped by probably 4 or 5 people with knives and broken bottles, and I gave them everything I had, but I was kind of cut up and pretty much blood all over me. I knew I was okay, but I knew I needed to go to the hospital, so I flagged down a car, and I went to the hospital where I had worked 15 years or 20 years before then, the Beira Central Hospital. And it was a pretty ugly place. I went into the hospital, there were no chairs to wait in, and I was bleeding, my pants were pretty much filled with blood. I tried to find my 25 cents, but they'd taken everything from my pockets, so because of that, they treated me free. After maybe 15 or 20 minutes of waiting, because I was the only one obviously bleeding in the room, they gave me a seat and then went to one of the wards, was put into bed. Pretty crazy situation. I was by no means the most urgent person there. Ultimately, about 15 minutes later, somebody came and took my blood pressure, which was perfectly fine. And after maybe an hour, I was treated by a mid-level provider, somebody who I'd actually known 20 years before, who offered to sew up my hand and my leg and my face, and which he did. Very nice job. And he was going to sew up a little cut that I had on my nose. And you don't want to have a huge scar on your nose. So, and he had some 3-0 ethylon for that. And those of you who are doctors know that it's kind of thick, 3-0 ethylon. So I said, well, do my arm, do my leg, but let's wait on the 3-0 ethylon, okay? And so I left, still bleeding, kind of put a pad on my nose. And I was with a couple of my colleagues, and we decided, we knew that, after several years of lots of international aid, there had been a big push, and particularly in Mozambique, for private sector healthcare, and there was a private clinic, so I thought, wow, here's an opportunity to try the private clinic. So I went to the private clinic, which was, maybe a half an hour down the road in the center of the city. It was, in fact, open. It was, 8 o'clock at night, so it wasn't exactly late. No doctor was there, but there was a nurse there who had good telephone contact with the doctor. Incredibly clean, quite beautiful, really nice place. And so I said, well, I'm fine. My blood pressure is fine. Everything's okay. All I need is just, if somebody could just put a little, if you had some 6-0, that would be great. 5-0 would be really nice, So they called the doc, and they charged me about $25, which is a month's wages for most people, to go there. And the only thing they had in that place was that they didn't have any tetanus immunizations. They did not have any ethanol at all. And in fact, the best they had was 3-0 catgut, if you know what that is, achromic. And so I just left, and I tried to get a steri-strip, but they didn't have a steri-strip, so we just got a little elastoplast, and I put it over my nose, and it worked really well, and I have no scar. So the story is everything's fine, but it was a really interesting reflection on private care, because this was the best private clinic, but there were no standards, and it looked better. They had more access to doctors. They were making a lot of money, but I'm not sure if anybody was getting any better care. 3 days later, I went to the capital of the country because in this particular town, the HIV prevalence is about 32, 33%. It's the kind of place where you probably want to get a baseline HIV test. So our project had been working on setting up voluntary counseling and testing for quite a long time. I know exactly what a voluntary counseling and testing clinic should look like, but we didn't have any in Maputo that I could go to. So, I was running the morning I was leaving, and I thought, there's a place called 222 downtown, and so I decided to go into the place and to see if they would just do a quick HIV test on me, just so I'd have a baseline. And they said, oh yeah, sure, we can do it. Charged a fair amount of money. Again, it was probably about $15 for my HIV test. And no counseling, no nothing. They said, you want a test? That's fine. They drew venous blood and gave me a sheet of paper, a completely open paper with the results of my HIV test. And I was thinking, whoa, is this what happens in the private sector in Mozambique? Well, I don't think it's fair to generalize, but it does raise some questions in my own mind about the kinds of things that you can get in the private versus public sector, because it looks good to a lot of people, and particularly the poor, when you see a clean clinic with nurses with clean uniforms, it looks like you may be getting better care. I'm not sure if that's the case. So in the rest of my time after these long stories, there are 3 points I want to make. One is that up until a couple of years ago, I think you would say that government health systems are far inferior to what they were 2 or 3 decades ago in most parts, at least of Africa, which is where what I know best. I think they're getting better now. Second is that there are some theoretical advantages of government systems, but it's hard to measure when they're not funded. And third, that the new efforts of funding the bubble that Chris talked about to scale up HIV, TB, malaria, et cetera, has actually substantially improved government services and increased the chances to show some advantages for public sector care where you could meet those theoretical advantages over private care. So one, why are health services worse than they were 30 years ago? And if so, why? And I think that it's important, those of you who have heard me talk before know that I'm fond of talking about structural adjustment programs and alma ata. But I think it is important to note that it was 31 years ago that we had our MDGs of the day saying that we could achieve health for all. We knew we could do it because, to a large extent, of the public sector experiences in governments like China, Cuba, Sri Lanka, Kerala, Taiwan, Singapore, South Korea, Hong Kong, Malaysia, Senegal, etc. Governments that had provided health care to their poor. And in many cases, they went from mortality rates of children in the neighborhood of 15 to 30% of kids nationwide not reaching the age of 5 to numbers between 2 and 5% of kids not reaching the age of 5 with universal health care pushed by public sector. There was evidence that public financed and delivered services dominated the higher performing, more equitable health societies at that time. The other thing that's important to note is that in 1980, 2 years after Alma Ata, Ronald Reagan was inaugurated as President of the United States, and he said that government is not the solution to our problems, government is the problem, in his inaugural address. And he ushered in an era that I would call of increasing privatization and reducing governments. At the same time, U.S. government policies contributed to a increasing and systematic debt throughout the poor world, and shortly thereafter, the World Bank, the IMF, imposed structural adjustment programs, which essentially were a package pretty cookie cutter, introduced in literally every country in sub-Saharan Africa and many poor countries of the world, of privatization, deregulation, and reduction of public spending and reduction of the public role. So from that period on, the early 80s until now, what we've seen is this anti-public sector approach, which is characterized by what UNICEF, USAID did with what was selective primary health care, then GOBI, then child survival programs, which were a way of sort of undermining primary health care, to private sector initiatives, to Bamako initiatives, to healthcare reform, user fees, et cetera. The World Bank, 1993 and 2004 World Development Reports, suggested the government should encourage private production, or private providers to serve those who can afford to pay, and to contract with for-profit or not-profit providers, private providers, to deliver in the government's behalf for those who can't afford it. That is, private sector both ways, with franchising and with a lot of other mechanisms. I think historically, I think to be fair, this does not really happen very frequently throughout the world, but certainly it's been pushed by the donors and particularly by the bank and the IMF. So as a result, what happened was that government budgets were slashed. Educational budgets were also slashed throughout Africa, so that what you had is the kind of situation I had when I went to the hospital in 2002. You had health facilities that weren't maintained, that were falling apart, whether it's the building itself or the furniture, the vehicles are not maintained, they're not purchased, workforce stagnates, salaries are dropped. We're an estimated 1 million to 3 million doctors short in Africa alone. Not just providers, but managers. There are not enough managers to be able to order the drugs, to make sure the stuff gets there. The whole system of drug supplies has to a large extent been taken over by donors and NGOs, and so when you go into ministries of health, and we work very closely with ministries of health in a couple of countries in Africa, that they don't have systems anymore because they don't have the experience because the donors and the private sector has taken it over. You may have special systems of care, particularly immunization care and traditional birth attendants and other systems of care that are done and implemented outside of standard government structures, so that you have the situation where the government looks very, very bad and the special services look much better, whether it's the facilities being painted or the providers having the kind of equipment and materials and even clothing that they need. And user fees have reduced access. So what you have is essentially a shadow of the kind of situation that you had in the early 80s in most countries of sub-Saharan Africa. Now that's not to say it was great, but I can tell you from my own experience that things looked better, felt better, and I think were better. Now the framework for discussion has changed. So we hear about government failure, we hear about public-private partnerships, privatization, franchising, social entrepreneurism. It's an ideological perspective that is driving our thinking, but as I suggested before, there's not a lot of evidence that these kinds of things worked. I spent a fair amount of time in the Philippines and had the chance to visit 3 franchises that have been funded by public sector, by USAID, to provide health care for the poor. They were called friendly care clinics, and they were the colors of McDonald's clinics. They were kind of cute, so it was a franchise. And you'd walk into these places and they were very nice, and what they were trying to do is to charge a little more for the rich so they could subsidize the poor. But everybody I talked to, including the people who were very invested in these clinics, would say over and over again that the poor just can't afford the low prices that we charge. So ultimately what they did is they just took this level of care of the near poor but not the poor. So getting to the second and third questions is that why should we have any hope of developing adequate government health care? What are the theoretical advantages, and what have we learned in the past 5 years from AIDS treatment and some of this bubble funding that we've talked about? And I'll say essentially 4 things. One is that access in government health care is likely to be better given the fact that most governments in most parts of the poor world have an existing, although not well-maintained, network of clinics and services that far outweighs anything that could be provided by either a network of international NGOs or even a private sector network. Many of them are falling apart, for sure. But in those rural areas where no private doctors go, with a couple of exceptions like in India and Nigeria and some other places, it's very, very hard to get these kinds of services out. It's hard to allocate workforce. And our experience in HIV treatment is that we've been able, with the government of Mozambique, to expand HIV treatment at 2 to 3 times the rate of what could be done with NGO treatment or with private sector treatment, simply because of the network of clinics that provide a tremendous opportunity for investment in an institution that already exists and that will be there 4 or 5 years from now, or 10 years, or 20 years from now. Whereas if you invest in NGOs, if you invest in private sector entities, it's not terribly certain if they're going to be there, particularly the NGOs, whose half-life tends to be between 2 and 5 years. Second is quality. With government services, you can standardize things. You can standardize drugs, algorithms of care. You can standardize laboratories. Our experience with NGOs in Ivory Coast, where we're trying to set up some mother-to-child transmission prevention programs, was that a woman who went to antenatal care had to make an average of 5 to 7 stops in different physical sites to be able to get antenatal care through the fragmented system that was served by the NGOs. Whereas once we started working with the government, they could do one-stop shopping. Third is cost. Private sector can have some efficiencies, but when you look at the experiences that we've had, for the most part, private sector is more expensive. They pay their providers more. Providers should be paid more, but the high-end providers tend to get a tremendous amount more. And if you look at, for instance, the budgets of private sector entities, particularly the budgets of NGOs, if you put them into this private sector basket, that our experience in Mozambique is that an NGO with 15 to 50 workers might have a budget that's double that of the Ministry of Health that has 500 workers, far less efficient. Churches have worked in very productive partnerships as part of NGOs, probably are very cost effective, but it's a very different kind of model, and we can talk about that if we have time. And then finally, accountability. The accountability issue, I think, is key because governments are not necessarily accountable, but they're theoretically accountable. Whereas private sector entities, NGO entities, tend to be accountable to their donors, even if they talk a different level of accountability. Corruption definitely happens, although it happens in the public sector, it happens in the private sector, and I'm not sure if it's worse in either. It's probably worse in private sector, is my guess. There are private health delivery benefits. I think that if you're looking at hair transplantation, that I'd rather have the private sector cover those marginally beneficial services, like cosmetic surgery, than the public sector, and that there are going to be some trade-offs and some hard decisions that have to be made around what the public sector should and should not offer. So we do need some essential services, some of the kinds of things that Chris has worked on about understanding what services make the most sense, I think are really key there. So overall, government and private health care will very likely continue to coexist. There will be big differences between urban and rural health care. And I think that we have to learn to live with both in coexistence. The private sector needs to be held accountable by the government for the services it provides, but I think there still is a huge role for the government to play, particularly for services for the poor. If you want universal and equitable access to health care, I believe the public sector must be made to work as a majority provider as long as the marginalized poor are in the majority. Thank you.
Thanks, Steve. I think there's people in Bureau who just thought you had thick skin from when they worked with you 20 years before.
There you go.
Where's Chris? There he is.
Okay, so I'm going to try and provide a little bit of a framing for this discussion, because I think Steve's reflections just now point out a lot of the confusion about terminology here when you have a topic like private and public roles in health, because I think it's very important to distinguish all the different functions that health systems do, and that you can think about government and non-government actors' role in these different functions. For example, Steve's own work, which is a private entity, Health Alliance International, is an example of a public-private partnership. So I'm assuming that most of your comments weren't saying that HAI's work is bad, and you were looking more at a certain subset of the private sector on the provision side. So again, language matters a lot. This is one framework that the World Health Organization promulgated around 2000 of thinking about health systems, that every system has to deliver services, provision of services. Every system needs to train health workers and produce drugs and deliver the ingredients required for providers. But there are two key functions in addition. Bottom left here is financing, who pays. And the function of financing can be done many, many ways, and I'll talk about that distinction. And then the last function, and probably the one that many of us believe is the most important, is the stewardship role, which is the role of guiding the health system. That includes planning, regulation, setting the rules of the game, whether it's a public or private financed or public or provided system. And that sort of monitoring, surveillance, epidemic response, all those functions belong to stewardship. And I think the experience that most of us have is that only government can undertake that stewardship function. There's nobody else who can fulfill that role. And a lot of the failures on public or private side that Steve was alluding to are actually failures of stewardship, to appropriately regulate the private sector. If you're talking about a for-profit sector where you really need rather intense regulation, I believe, to make it work. And that capacity to undertake effective stewardship is a very big part of this strengthening the capacity of government to manage quite complex systems. So what's the dominant view in not the US policy community, where they're a little bit more right of center, but the dominant view in the global health systems policy arena? And I think on the financing function, most of us believe that finance should be undertaken by government. First of all, the evidence is overwhelming that prepayment mechanisms are better than payment at the point of service in the terms of giving access and avoiding catastrophic payment or medical impoverishment. So not too many people, maybe a small group of diehards at the World Bank left, who would actually want to have payment at the point of service. Pretty much everybody's speaking the same language about prepayment. In the area of prepayment, I think there's a smaller group, but still the majority of us, who would believe that the most efficient way to organize prepayment in low, middle, and high-income countries is through taxes or social health insurance, not through private health insurance. But it's a little bit harder to say here is irrefutable evidence that you can't use private health insurance, because many systems, Switzerland being an example, blend that by having mandated private insurance, and so it becomes unclear what's private, what's not. So essentially everybody has to have insurance, but the insurance companies are privately managed, but because there's a mandate and it's tightly regulated, it really looks like social health insurance. And so there's this sort of gray zone in that arena where some people would disagree. And the last observation on finance is that we're now living in an era in low-income countries where 30 to 40% of health spending by the public sector is from donors. And that means that effectively donor assistance is a form of prepayment if you're the individual benefiting from those services, or can be, as long as there isn't some sort of user fee associated with it. Now, just evidence on the medical impoverishment part. This is all the sort of 100 countries for which there's data on catastrophic health payment. On the y-axis is the fraction of households in a year that experience medical catastrophe, that is paying more than 40% of your disposable income on healthcare in a year. And in the x-axis is the fraction of payments that are out of pocket. And this is a very clear, strong relationship that if you pay more out of pocket, no surprise, there's more medical impoverishment. There is variation at the same level, and that has to do with the way you provide protection, whether it's hospitals versus outpatient, et cetera. So it's a little bit more complicated than just get rid of user fees, but that's a very big part of the whether it's in the public or private sector. Now, where the controversy lies Although, of course, you'll still find some people arguing for user fees or for private health insurance, but not too many these days. Where the controversy lies is on the provision side, as Steve was alluding to. And there, the evidence, I believe, on both sides of the story is pretty unconvincing. I don't think you can say there's compelling evidence that public provision or NGO provision or church, faith-based organization provision or private for-profit provision is better or worse. I think everybody can show cases of failure, and everybody can show selected cases of success. And to say that there's sort of, as on the finance side, where there's pretty strong evidence, I believe, it doesn't really seem as compelling. Think about systems that we think of as pretty public, the National Health Service in the UK. Well, all the GPs are private, 100%. None of them are government employees. They're all private contractors. It's public finance, private provision, highly regulated. So, it's not at all clear when you think of some of these success stories or examples that people tend to think of, even what is a system on the provision side. So I think Julio Franks, who had been Minister of Health in Mexico and the architect of a health reform in Mexico, framing of this is rather nice to illustrate the subtlety that's required to think about the roles of government. This is on the left panel, his rendition of Mexico pre-reform, where you had these vertically integrated but fractionated healthcare systems. One for the uninsured, run by the Ministry of Health, paid for by taxes, the far left, the insured, high-income groups, private health insurance, private providers. On the uninsured, you had the poor who were going to the Ministry of Health, getting low quality of services, often poor, drugs not present, poor access to care. And then you have the middle class getting the private insurance. The far left is the social health insurance system just for those in formal sector employment. And what the concept behind the Mexican health reform was to reorganize the system horizontally so that the Ministry of Health's primary role was stewardship, regulation, setting the rules of the game, creating the human resources, doing certain public health programs. That financing would be through an extension of social health insurance to the whole population through a variety of complex mechanisms, and delivery would eventually turn into this pluralistic system with social health insurance providers, Ministry of Health providers, and private providers, all on a level playing field, subject to the same regulations, the same oversight, and the same fee schedule. And that's the vision for this reform. And it's just a reflection that when we talk about the role of government, you've got to say in which space and for what purpose. So what's the numbers around health finance as context for the rest of our discussion? First of all, these are on the x-axis here, these are the WHO sub-regions, the 14 sub-regions of WHO, Southeast Asia, the poor countries on the far left, all the way over to Western Pacific on the far right. The red fraction is the out-of-pocket share of health expenditure. The pink is private insurance. And then green and light green is either tax-based or social health insurance. And the first observation is that there's enormous diversity in finance today, with the largest private sector component. This is finance, not provision. The largest private sector finance, and particularly out-of-pocket, in India and other parts of Asia. Sub-Saharan Africa, in the middle, Afro D and E, are sort of intermediate. The large private insurance component under Afro-E is actually just South Africa, and because of dollars, that dominates that picture. But it's in the middle, half government, half private. And I take slight issue with the claim, Steve, that we have seen a change in this picture. We have recently because of aid. This is pre the big scale-up of aid. But I don't believe in the 1970s that public-private split was any different in terms of finance. So we can debate that, but I don't actually believe that we know that. Now, what's happening to health spending in low and middle-income countries as a fraction of GDP? And this is the data from 1995 to 2006, recent analysis. And this is the fraction of gross domestic product spent on health, including aid. So including the dollars from outside, which is why we see this big bubble above the 2%, which is the typical historical average for low-income countries. We're now moving up on average to about 3%. And some countries like Malawi at that top point, 9% because of huge injections in donor assistance. But nevertheless, there's a slow increase in the fraction spent, but most countries on average are spending about 2 to 3% of their GDP through government channels on health. And the effective aid is to raise that from 2 to about 2.5, 2.75%. Okay, well, can we understand the future role of NGOs, the church organizations, and for-profit entities from some of the patterns, now not on the normative side, which is preferable, but what are we actually seeing happening? And so this is the chart on development assistance for health from 1990 to 2007, where total monies from north to south have gone from about $5 billion in 1990 to about $22 billion in 2007, with this explosion of money starting in 2002. But not only is there more money, but the channel by which that money flows has radically changed. So back in 1990, we had the world of USAID, the European bilaterals in red, and the UN system in blue. And everything else was pretty irrelevant. And as time went by, the orange there is the role of the World Bank and the regional development banks. It expanded. It reached a sort of peak in absolute and relative terms in the mid to late 90s in terms of loaning for health. And the role of the UN has grown, but its relative share has gone from almost half to about 15, 20%. So a huge reduction. And the purple there is the new vehicles. It's Gavi, it's Global Fund. And the part there that I think most people don't recognize in green is this massive expansion of the role of US NGOs and US foundations. Huge increase. There are now, more than $6 billion flowing through US NGOs focused on health in developing countries. That's twice as big as the UN system. It's bigger than the UN plus the World Bank. It's actually about this, only slightly smaller than bilateral flows. So just a dramatic change in the role of US NGOs operating in developing countries. And here's just another way to see that is the composition of the monies over time, the red and the orange being bilateral and NGO. So this is a fact. It's an empirical fact that there's been this huge scale up in their role. And the question is, where is it going? I suspect it'll continue to grow, just on an empirical point. And we can certainly discuss the merits of that. Now, I think this is my last slide, which is to point out that where the money goes, not only is the channel changing, but the money's flowing to not everybody proportionate to need, whether needs defined by health need or by poverty. It's some complex mix. So on the left panel here is total flows from 2002 to 2007. And on the right panel is the burden of disease. Total amounts, rank ordered by country. And India is the top of both lists. It's getting the most money and it has the most burden. It is upper low income in blue. The low income countries have the red dots and the middle income countries have the green dots. And you can sort of see where the arrows are going up. These are countries arguably, especially the red ones, that are sort of being underfunded because they have more burden, they're poor. In the rank order, so their rank order on burden of disease is higher, so a place like Bangladesh is getting much less than perhaps its income or its degree of burden would suggest. And some countries, the darlings of the donors, are the dashed lines dropping down. These are the ones getting aid far in excess of their need, especially if you focus on the red dots. Ethiopia, Uganda, Kenya, Mozambique being examples. Other African countries in the flip side of that are places like Nigeria that are on this, and many other smaller African countries that are even off this list. So the last question, which is to connect into this finance question, not the provision side, but that complicates the story on what we would like to see happen, is the question of additionality. That is, what do ministries of finance do when money comes to government? So if you're going to give money to government in developing countries to fund government provision or government contracting, either way, if money flows to government, what happens? And although the analysis is preliminary, it does seem pretty compelling that if you give $1 to a government to spend on health, the Ministry of Finance takes away 60 cents to as much as $1 away. So you give $1, they take away $1. So there's no net benefit to the Ministry of Health. And so this is actually a non-trivial issue. Because if you think about Gordon Brown's high-level task force for innovative health financing meeting right now, coming up with a recommendation that we need another $30 billion a year to deliver on maternal and child health care needs for the MDGs. If this is true, then if you want to give the money to governments, then you actually need to give $75 billion to achieve the $30 billion scale-up that's required. If you give money to NGOs, US NGOs mostly, it doesn't seem like government does anything. They don't seem to react. And so you could make a case that giving money through NGOs may certainly be a better buy in terms of money, but has all the other complexities of how do you do that and yet have the government regulate that provision of care such that it's free at the point of access to care, it's equitably distributed, and has high quality. All of the things that are critical in the stewardship function of government. So I'll end reflections there. Thanks.
Well, thank you to both of you for kicking us off with a lot of content, I think, for a discussion. Chris, I want to start with a question to you about your slide with the arrows. Just doing a quick look, the ones that seem to be receiving more funds compared to their DALYs, the African ones at least, I think were all PEPFAR countries. So maybe talk a little bit about how the President's Emergency Plan for AIDS Relief, that $15 billion which went into only 15 countries, most of which, 12 of which were in sub-Saharan Africa, how does that distort that data? And if you took out PEPFAR, does the data look more sensible?
No. So just a few reflections there. First of all, we should remember that the $15 billion in PEPFAR doesn't all go to countries, actually. It counts a whopping big chunk at NIH. So if you actually go back and count, of the $15 billion, about $7 billion were already being spent in existing budget lines. So it really was only $8 billion extra. And that's the money, not even all of it, but most of it going to countries. So, I think which is why the scale up in the new legislation is even bigger than what it appears to be, because it's, a huge scale up on top of that base amount of money going to existing domestic programs like NIH's research portfolio for HIV. If you take away absolutely, the US pattern for PEPFAR is dominant, but every country has their favorite set of clients, in a sense. And so you look at where Australia spends their money, it's a bunch of client states where they're the dominant donor. And the same is true for the UK. They tend to preferentially give to Commonwealth countries. So it would make it slightly more rational, but not much. You would find, for example, that there's overfunding of middle income or upper low income countries in Latin America particularly. They get per DALY a lot more money than African countries. There's only a handful of exceptions. Namibia, interestingly, tops the list in terms of dollars per DALY in sub-Saharan Africa. And, obviously complex political issues there.
One other clarifying question about some of your data. When you showed the dramatic increases in the role of obviously the Global Fund and Gavi, but then particularly the U.S. NGOs or international NGOs. Where is that funding? Is that government funding like PEPFAR? How are you accounting for that? Is that where is PEPFAR on your slide? Is it under the bilateral funding or is it in the NGO funding?
So we have lots of different slides. The one I showed is what we call channel, and so it's the penultimate handler of the money. So in that one, the PEPFAR money to U.S. NGOs was shown under NGOs.
Right.
There's others where we backtrack and show by source, public or private, from the sort of original source payer. The interesting thing on the NGO is that huge amount of NGO flows, it's about 1/3 government money, 1/3 private individual contributions, and 1/3 drug donations and equipment donations from the private sector corporations, which we believe are probably overvalued because they use wholesale U.S. prices on their tax returns. which is the basis of those numbers. And so that's probably an exaggeration based on overvaluing those drug donations and equipment donations.
Good. Steve, let me ask you to react to some of the data.
Yes, okay. Well, let me just, I'd like to react to the sensible funding issue, because I totally agree with both of you around the issue that it's not terribly sensible. And I think if you look at funding over the last, certainly since the 70s, that the flows of money are, I think, mostly interesting in terms of trying to identify how and where they flow in terms of perhaps other drivers besides health. For years, USAID has had 4 basic objectives, only one of which could be considered sort of in the humanitarian health realm, and the others were security, economic development, and opening markets. And if you look at the issues around security, if you look at the issues of which countries get what kind of aid over the years, it goes from Pakistan to El Salvador, back to Pakistan, to Egypt and Israel, of course, for many years, being at the top of the list. And it oftentimes reflects, I think, as much security concerns as health concerns. Now, obviously, that's just the U.S. Other funders, I think, don't have quite the volatility from country to country. But I do think that it could be considered sensible in the context of what the objectives of the aid at least are perceived to be. My question about the data is pretty much along the lines of what Chris was saying, is that my focus was primarily on delivery of services. Okay, and if you look at, and particularly the last point that you made about, well, maybe we're better off, instead of giving money to governments where there's marginal additionality to that money, maybe we should give the money to the NGOs. Because when you give the money to the NGOs, it just goes to the NGOs, and the money to the Ministry of Health stays the same. Well, I would suggest that, at least from what I've seen, and I haven't seen the money flows specifically in each country, but what I've seen is that ministries of health are remarkably underfunded, and NGOs are remarkably rich. And if you exacerbated that at all, it would be hard to even go to some of these places. I mean, the people who work in NGOs, right now, if you're in Maputo, Abidjan, Nairobi, you have traffic jams of Toyota Land Cruisers that are all driven, that all have NGO stickers all over them. They're the new luxury elite, of most countries that are recipients of aid. It costs in the neighborhood of $200,000 per high-level provider, nurse, doctor, that some of the PEPFAR organizations hire, as opposed to whatever it would cost to pay a Mozambican or a Zimbabwean or an Ethiopian doctor between $300 and $600 a month. The kinds of inefficiencies you get with NGOs are remarkable, and if you think about how, what the problems are with delivery of services, and the problems of delivery of services in most places in the poorest parts of the world are that you can't get the providers and you can't get the stuff that the providers need, whether it's drugs, whether it's laboratory equipment, whether it's vehicles, communication, or monitoring and evaluation. You can't get those to the places where they're needed adequately. And delivering that money to NGOs may do it, but it's remarkably inefficient, and those NGOs are likely not to be around between 2 and 5 years from then. So you're going to be back where you started. So my concern is, what is this going to look like 5 or 10 years from now, and how are you going to develop some sense of services? Well, maybe Columbia, University of Washington, and some of these other entities should be the health providers for Ethiopia and Mozambique 20 or 30 years from now, but I doubt it. I think what we really have to do is to try and understand what local institutions are likely to be around to deliver services, and I don't see money going into NGOs as being the optimal way to make that happen.